Because of the nodules that occur with rheumatoid arthritis, the patient is at risk for a disturbed body image. Because steroids are highly prescribed with patients for rheumatoid arthritis, chronic steroids can cause a moon-faced appearance, acne, or buffalo humps on the back of the neck. Chronic steroid use can also place the patient at an increased weight gain as it causes the patient to have an increase in appetite and fluid retention. The cause of systemic lupus erythematosus is unknown. However, several precipitating factors may cause, including medications, stress, genetic factors, sunlight or UV light, and pregnancy. Systemic lupus is a chronic progressive inflammatory disorder, and it is an autoimmune response. Many cases of lupus may involve some degree of kidney involvement. Many patients may live for many years with proper medication regimen. The immune complexes form in the serum and organ tissues which cause inflammation, damage, and destruction. This invades organs directly or causes vasculitis, which deprives the organs of arterial blood and oxygen. Lupus affects women 10 times more than men, and usually diagnosed between the ages of 20 and 40 years old. Any or all body systems may be affected by lupus. Because lupus nephritis is the leading cause of death, carefully assess for signs of renal involvement, including changes in urine output, the presence of protein in the urine or blood in the urine, and fluid retention. Patients with lupus have major skin manifestations, including dry, scaly, raised rash on the face called the butterfly rash. This is a signature or hallmark feature of lupus. This may also be present on other body parts. Lesions may have scarring due to exposure to sunlight. Teach your lupus patients to avoid extreme sunlight and sunscreen protection. Patients with lupus may also experience joint inflammation similar to rheumatoid arthritis. Fever and fatigue are common findings. Patients may struggle to get a diagnosis as their symptoms may overlap with rheumatoid arthritis. Assess the patient's psychosocial and family support. Administer topical or systemic corticosteroids and non-steroidal anti-inflammatory drugs to prevent skin breakdown. Topical cortisone preparations reduce inflammation. Acetaminophen is given for pain. Anti-malarial drug hydroxychloroquine decreases the absorption of UV lights and decreases the risk for skin lesions. Remember, chronic steroid use leads to a decrease in the patient's immune system. Alopecia or loss of hair is common with lupus. Fever is a major sign of exacerbation. Remember to teach your patient to avoid exposure to sunlight or ultraviolet light and avoid high temperatures of sun, such as in the summer months. Supportive therapy is given as major organs become affected. Note that lupus nephritis occurs early in disease process and if left untreated is one of the major causes of death for lupus patients. Provide supportive therapy as well as emotional support and encourage the client to verbalize their feelings. Teach your patients that their hair should receive special attention because hair loss is common. Use mild protein shampoos and avoid harsh treatments such as permanents or highlights. Teach your patient to monitor their body temperature. Fever is a major sign of an exacerbation, and patient can become seriously ill. Discuss possible effects on lifestyle, including fatigue. Women are more affected than men with scleroderma. Scleroderma is also known as hardening of the skin, and left untreated has a high mortality rate. Raynaud's phenomenon can occur with scleroderma, as well as esophageal dysmobility, so aspiration precautions are important for a patient with scleroderma. Other physical findings include sclerodactyl or scleroderma of the digits, joint pain, pitting edema, diffuse hardening of skin, decreased range of motion, weakness, joint contractures. Organ damage primarily has renal and cardiopulmonary systems affected. The esophagus loses its motility. Patients experience extreme dysphagia. In the lungs, fibrosis of the alveoli occur, creating impairment of exchange of airway. Of scleroderma is to slow the disease progression. Systemic steroids and immunosuppressants are used. Of scleroderma is to slow the disease progression. Systemic steroids and the most common inflammatory arthritis in older adults. The cause and treatment of gout has been firmly established, and a classic case of well-advanced gout is seldom seen today. Primary gout is the most common type and results from one of several inborn errors of purine metabolism. End product of purine metabolism is uric acid, which is usually excreted by the kidneys. For women, primary gout is inherited as an X-linked trait. Males are affected through female carriers. Secondary gout involves hyperuricemia or excessive uric acid in the blood caused by another disease. After repeated episodes of acute gout, deposits of urate crystals develop under the skin and within the major organs, particularly in the renal system. With chronic gout, inspect the skin for tophi or deposits of sodium urate crystals. Although tophi are rarely seen today, they may appear on the outer ear, arms, and fingers near the joints. The tophi are hard on palpation and irregular in shape. Gout is one of the earliest diseases to diagnose and treat. Drug therapy is the key to managing patients with gout. Drugs used for acute gout are different from those used for a chronic gout. Patients with an acute case of gout use a combination of collagen and NSAIDs. Chronic is allopurinol or Uloric is drug of choice. Take after meals and drink a glass of water with each dose to prevent GI distress. Drink at least 8 glasses of water each day helps to prevent renal dysfunction. Avoid organ meats, shellfish, and oily fish with bones such as sardines. Avoid fad starvation diets and avoid alcohol intake. Encourage your patients to drink plenty of fluids to prevent the formation of urinary stones. Lyme disease is a systemic infectious disease caused by an infected deer tick. Patients go through several stages before recovery. Stage 1 is flu-like symptoms with a round or oval, slightly raised rash, pain and stiffness in muscle and joints. Patients may present with a bull's-eye lesion. Stage 2 occurs 2 to 12 weeks afterwards and may cause the patient to have carditis and dysrhythmia. Dyspnea, dizziness, palpitations, and meningitis have also been reported. The late stage of Lyme disease occurs months to years and may leave the patient with memory and thinking problems. Psoriatic arthritis is most often diagnosed between the ages of 30 and 50 years old in men and women. Quality of life can be severely affected as patients experience chronic joint pain and inflammation. Fibromyalgia is a chronic pain syndrome, and it is not an inflammatory disease. However, arthritis and other comorbidities are commonly present in patients diagnosed with fibromyalgia. Pain is typically described as burning and gnawing and may cause disability for patients. Pain and tenderness typically comes and goes, but worsens in response to stress, increased activity, and weather. Proper sleep and rest is an important aspect of treatment for fibromyalgia. Teach your patients to get enough sleep every night to help reduce pain. As antibodies are made against glomerular basement membrane and alveolar basement membranes, the lungs and the kidneys are primarily affected in Goodpasture syndrome. Assessment includes assessment of airway and kidney function. Common findings for Goodpasture syndrome include shortness of breath, hemoptysis or spitting up of blood, decreased urine output, edema and weight gain as kidneys become increasingly affected. Hypertension and tachycardia are common as well. Corticosteroids and plasmapheresis are the primary treatments for this autoimmune response. Monitor urine and renal function is a priority nursing intervention. Dermatomyositis causes fever, fatigue, and a rash followed by muscle pain and weakness. It eventually causes systemic muscle atrophy. Patients experience extreme dysphagia. Comfort measures include swallowing precautions, nutritional support, PT and OT support. Treatment is with high doses of corticosteroids and immunosuppressant. Methotrexate, intravenous immunoglobulin G, and cyclosporine are the most common medications given. Acquired immunodeficiency syndrome, or AIDS, is a viral disease caused by human immunodeficiency virus, which destroy T cells. Remember, T cells are part of the inflammatory response that helps destroy viruses within cells. AIDS puts patients at an increased risk of infection and malignancy. It is the most common immune deficiency disease in the world and has caused a worldwide epidemic. When the immune system fails to recognize infectious agents, severe local and systemic infections are not suppressed or controlled. Patients with AIDS are often leukopenic with a white blood cell count of less than 3,500 cells per millimeter 3. Patients with HIV disease and AIDS usually have a lower than normal number of CD4 cells where the number of CD8 cells remains normal. Antibody tests are used to measure the patient's response to the virus, the antigen, rather than to measure parts of the virus. When the body is infected with HIV, the body makes an antibody to the virus, which usually occurs within 3 weeks to 3 months. The ELISA test is an inexpensive and accurate test. The patient's serum is mixed with HIV grown in a culture. If the patient has antibodies to HIV, they bind to the HIV antigen and can be detected, resulting in a positive test. However, this test can be negative even when the person has an HIV infection if the test is performed before the antibodies are made in sufficient amounts. A Western blot test is used to confirm the diagnosis with the results of the ELISA test when they are positive. This test is more sophisticated and expensive than the ELISA test. A home test kit requires that a drop of blood be placed on a test card with a special code number. The card is mailed to a lab where the blood is tested for HIV antibodies. OraQuick is a newly approved HIV home test kit. This test uses oral transmucal exudate and results are ready in 20 to 40 minutes. The manufacturer recommends that the test be performed at least 3 months after a risk event has occurred. Viral load testing, also known as viral burden testing, measures the presence of HIV viral genetic material or other viral proteins in the patient's blood. These tests are quantitative and indicate the level of viral burden or viral load, which is useful to monitor disease progression and treatment effectiveness. Other lab tests monitor the patient's overall health and detect or diagnose any infections to other problems related to HIV disease. The transfer of infected blood or blood products, unprotected sex with an infected person, fetal exposure through placental transmission of an infected mother, and exposure of maternal body fluid during birth, and frequent vaginal yeast infections are common risk factors for the development of AIDS. Age, ethnic group, gender, socioeconomic factors, lifestyle decisions, and geographic locations are also factors that place a person at increased risk for AIDS. Some patients develop an acute infection within 4 weeks of first being infected. Signs and symptoms of early infection include fever, night sweats, chills, headache, and muscle aches. HIV uses its enzyme integrase to get its DNA into the nucleus of the host's CD4 and T cells, and it then inserts it into the host's DNA. This action completes the infection of the CD4 and T cells. HIV particles are made within the infected CD4 T cells using the metabolic machinery of the host cell. Once the new virus particle is finished, it fuses with infected cells' membranes and then buds off in search of another CD4 cell to infect. The smaller the CD4 count, the patient is at increased risk for more infection. In the primary stages of HIV, the CD4 count is at least 800. The patient may experience early symptoms such as flu-like symptoms, fever, and malaise. In Category A, the CD4 cell count remains more than 500 cells. There are no clinical problems evident. Viral replication is occurring within the body, and this process can take as many as 10 years or longer. As the disease progresses, patients enter into category B. CD4 cells count are less than 500, and the patient begins to exhibit symptoms such as persistent fever, weight loss and diarrhea, peripheral neuropathy, herpes zoster, candidiasis, cervical dysplasia, and oral hairy leukoplasia. The final category of AIDS is category C. The CD4 cell count drops to less than 200. This occurs when a variety of bacteria, parasites, or viruses overwhelm the body's immune system. Assessment findings of the AIDS patient includes extreme fatigue, loss of appetite with unexplained weight loss, swollen glands, unexplained fever for more than 1 week, night sweats, unexplained diarrhea, dry cough, white spots in the mouth and throat caused by an overactive yeast infection, which will lead to ulcerations in the throat, making it painful to eat and swallow. Also present are painful blisters, painless purple-blue lesions known as Kaposi sarcomas, confusion and mental status cognition changes, vaginal infections, resistance to treatment. Candidiasis, or overgrowth of Candida fungus, occurs because the immune system can no longer control fungal growth. On examination of the mouth and throat, you may see cottage cheese-like yellowish white plaques and inflammation. The weakened immunity increases the risk for some cancers. These include Kaposi sarcoma, lymphomas, invasive cervical cancer, lung cancer, GI cancer, and anal cancer. Kaposi sarcoma is the most common AIDS-related malignancy. The risk for Kaposi sarcoma appears to be related to co-infection with human herpes virus 8. Kaposi sarcoma develops a small purplish-brown raised lesions that are usually not painful or itchy. AIDS dementia complex, also called HIV-associated dementia complex, refers to the manifestations of the central nervous system involvement. Ways to enhance a patient's independence when home are use of clock and calendar to make time reality easily visible. AIDS wasting syndrome is not due to a single factor. It may be a result of altered metabolism from cancer or infection. Diarrhea, malabsorption, anorexia, oral and esophageal lesions can all contribute to persistent weight loss, and the patient may appear quite emaciated. Skin changes include dry, itchy, irritated skin and many types of rashes. When the platelet count is low, petechiae or bleeding gums may be present. Kidney problems involving HIV-associated neuropathy are common. A person who has HIV is monitored on a regular basis for changes in immune function. The decrease in immunity places the HIV patient at an increased risk for the development of frequent infections, severe opportunistic infections, and an increased risk for malignancies. AIDS is a disease with a mortality rate of at least 60% for adults. At this time, there is no available cure for AIDS. A major focus for healthcare is prevention of HIV infection through patient education, community care education, and the use of standard precautions. Community education to prevent the spread of AIDS focuses on safe sex practices and also the handling of needles and sharps after use. Patients who use needles repeatedly or more than one time need to be taught that needles need to be rinsed with bleach and water before a second use. Community awareness that AIDS can be spread through sexual contact, parenterally through needles, or perinatally through the birth of a child with an infected mother. Also teach your community that HIV is not transmitted casually by sharing household utensils, towels, linens, or toilets, or by mosquitoes or insects. Personal life factors can affect timing and progression of the disease, including frequency of re-exposure to HIV, presence of other sexually transmitted diseases, nutrition status, and the patient's stress level. For people who have been transfused with HIV-contaminated blood, AIDS often develops quickly.